Hello, everyone. Thank you for joining us today from wherever are you in the world. We have a very exciting seminar for you planned on the Pathway to Excellence for ICHOM Accreditation. Now, when we start, I'd just like to ask if everyone could please put the country that they're from in the chat so we have an idea of where everyone is joining us from. My name is Lewis Green, and I am the project manager for the accreditation program here at ICHOM, and I'll be your moderator for today. Before we begin with the actual content, I just want to discuss a couple of other initiatives that we have here at ICHOMS that you can get involved in. The first of which is our implementation directory. So this is a really great way to showcase if you're implementing one of our ICHOM sets. It's a big world map that has a pin for each organization. We're always looking to include new organizations. So if you haven't already, please do scan the QR code, fill out the survey, and get yourself added to the map so that we're able to recognize the work that you're doing. The next thing is our conference. So this will be in the wonderful city of Montreal at the end of the year, 7th to the 9th of December. We have a really, really exciting kind of lineup that is starting to come through. Certainly not something you want to miss, so please do register your interest as well. And the conference team has the call for content out at the moment too. So this can be in areas of case studies, patient engagement, payment models, system resilience, population health, prevention at scale, and tech innovation. So if you're interested in presenting in any of these areas, talking about them, please do apply. I'd also just like to note that the deadline is the 13th of February, so not too far away. So make sure you are nice and organized and get your application in advance of that. Excellent. Now, with those things sorted, I want to give a bit of an overview of the accreditation program to give some context for the talks that you'll be hearing a little bit later. So our program is unique in that it focuses on the outcomes that matter most to patients as opposed to processes or experience. And we've also designed our accreditation program to be in three different levels. And this is to really reflect the difference in maturity that we know organizations are going to have with their implementation of an ICHOM set. So at that first level, we're really looking to see if you have those foundations in place, those systems and processes that allow you to reliably collect data and also start to analyze that data. At that second level, we're starting to look at how you're using that data to improve care. So is that information being shared across clinical teams with hospital leadership, enabling it to make process improvements so that your patients get better care at the end of the day? And then at that third level, we're really looking for what we see as global value-based healthcare pioneers. So organizations that are really demonstrating these improvements, raising the bar both regionally but also internationally. And so those are kind of the three levels. We find that organizations fit into at least one of these when we talk to them. Now, organizations that take part in the accreditation program obviously derive a lot of benefit from it in a number of different ways, but I just wanted to highlight here four specific examples. So of course, we have improved patient outcomes, and we'll be hearing a bit more about this from our speakers. We have stronger collaboration between teams within the organization. You obviously get recognition of that excellence through our networks and the kind of publications that we do. And then we also get continuous improvement. So at the end of each review for an application, we produce a report that we give to the organization that really highlights any improvement areas that we see could continue to provide better care to patients. And organizations really appreciate that. Now, we've been extremely fortunate to be able to partner with several organizations around the world to kind of raise the profile of the accreditation program through their networks, and a massive thank you to each of them. I would like to especially mention Capidev. So Capidev has been a partner with ICHOM since 2018, and they've also worked as a co-development accreditation partner to really help us refine the framework. And through the work with them, we know that we have a really rigorous methodology. We know that our accreditation program is internationally credible, and also that it's practical and implementable in a number of environments. And also, we'd like to thank Capidev for the ongoing support that they provide for us as we work through this accreditation program. Now, more recently, we've been working with ACHS International, and this has really been around the design and undertaking the in-person audit, which is part of the Level 2 assessment. And by working with them, we know that we have a best practice methodology. We also know that we've got consistent and reliable delivery of that accreditation program, and that they are able to support us with making credible accreditation decisions. Now, over 2025, we were very fortunate to accredit 13 hospitals across the world in 6 different countries in a range of conditions. The majority of these were at that level 1 that I discussed earlier, and we did also have our first level 2 applicants towards the end of the year from the BDMS group, those Bangkok hospitals, who will be speaking a little bit later. Now, I mentioned that organizations derive value in a number of different ways from the accreditation program, and one of those is through our Statista partnership. So this really is about recognizing hospitals that are measuring and reporting patient-centered outcomes, and by being ICHOM accredited, it streamlines the survey process that you need to go to. So not only do you get that benefit from being accredited by us, but also it makes the process when coming to the Statista survey much easier. So with that overview, I'd love to hear from anyone that is interested in the accreditation program. There's my email. You can very much reach out to me directly. We can start to have a conversation, or you can also scan that QR code to start your accreditation journey. So with that, I'd love to hand over to our first speaker, which is Sia Wanjin from Singapore General Hospital. And I will stop sharing my screen so that she can get her slides up. And just while she's doing that, I'd also like to remind everyone that there's a Q&A function on this. So please do put your questions into that chat and we will be going through them at the end. Over to you, Sia.
Thank you very much, Louis. So good day to everyone. Thank you very much for having us. I'm Wanjin from the Singapore General Hospital, and with me today are my colleagues, Associate Professor Deirdre, neurologist leading our stroke value-based healthcare work, and also Dusit, my administrative co-lead for the project implementation. So on behalf of our broader team, I'll be sharing on why we pursued ICHOM accreditation and also what the journey took in practice. So let me start with a brief picture of our context. So Singapore General Hospital is our country's first and largest hospital with over 1 million patient episodes annually. And as part of our vision to be academic integrated health system of the future, being a value-based healthcare provider is part of our embedded principles. And we do have a very comprehensive stroke service that has been around, and since 2019, we have been actively practicing value-driven care for this particular patient population with regular monitoring of acute care metrics, such as complications that includes urinary tract infection during admission and also door-to-needle times, etc. So these data are updated and reviewed every quarter and have informed multiple quality improvement initiatives over the year. However, like many centers, while we were strong in the acute setting, we do realize that we had limited visibility of our patients' functional recovery trajectory and needs after discharge. And that gap became increasingly apparent over time as we modified and improved on acute metric measurements. So that was when we began looking at also adopting the ICHOM stroke set to really better understand how our patients were doing from their point of view as well as after discharge, and whether we can then use that information to help to improve the care that we are already providing for patients. So the stroke set, we understand that it was co-developed by international experts together with patients, and therefore being internationally validated with prompts integrated will help us to systematically capture the patient's perspective and also help to have personalized goal settings for our patients. And we also thought that having a standardized set will help to align our healthcare professionals and teams with a common language to communicate with each other on patients' outcomes. And in the longer run, to also enable benchmarking and learning collaborative beyond a single institution eventually. So taking together, adopting the set gave us a shared outcome framework that we could act on. And so that was our starting point to this journey, which then naturally subsequently led to the application for the accreditation certification. Yep, so our journey broadly involved three phases. In the first half of 2024, we focused on patient journey mapping, which helped us understand where our patients go after discharge, and therefore who are the stakeholders who needs to be involved and at the relevant time points of care. And then alongside this, we also conducted feasibility and data gap analysis, which although it was tedious, it really helped to save time subsequently because we then knew where data resided, whether there are missing or incomplete information that we need to engage the relevant stakeholders. And then from the second half of 2024, we started small. We tested prompts collection and also the various post-discharge workflows and refined them iteratively. And finally, throughout the whole of last year, we took the learnings from the pilot and refined our workflows further to really implement on a bigger patient cohort, which then we managed to complete the first full data collection cycle and eventually achieve the level 1 accreditation in November. So overall, the process took around close to around 20 months end to end. And on paper, the process actually looks quite linear, although in practice, it really involved much coordination across the teams, stakeholders, and iterative revisions on how we implement. But ultimately, it was achievable with very clear scope and good communications with the key stakeholders that secured the buy-in for them to also support the process. So along the way, there were several important learnings that we took away. And so, for example, discharge pathways were quite disparate, and that differ depending on several factors that can include rehabilitation potential, patient preferences, specialty involvement, etc. And this made it necessary for planning, for clear planning, therefore to really understand which stakeholder to involve for all the post-discharge outcome collection. And it therefore meant that we have to work very closely with ward nurses, population health colleagues, our stroke wellbeing coordinators, rehab specialists, etc. So, and apart from engagement of the right stakeholders, we did also encounter post-discharge logistics challenging issues of collecting prompts. Particularly, some of them were like patients were not contactable post-discharge, or whether they had rescheduling of appointments, they had timing and mode of administration being some of the common issues that are faced by the various stakeholders as well. But there are good points where it was a good decision that we decided to start small and refine along the way. And so this actually helped us not to have initial overcommitment, and therefore the acceptance on participation from the various stakeholders. And it also helped to surface issues very much early on that we can then modify along the way. And with the issues identified and discussion on workflow alignments, we ultimately decided to centralize the prompts collection with our wellbeing coordinators with expanded head counts, and that have clarification on the roles, improve consistency in how data is being collected, and also address challenges with population health management, such as patients being outside of the institution's precinct. So we also created dashboards which help to provide the clinicians with early insights. And ultimately, we also decided that local adaptation was quite important for some of the variables to really improve relevance. For example, alcohol use variable was actually not consistently documented, but it also had less relevance in our local context. And similarly, we also recognize that at the suggested prompt time point at day 7 of discharge is cumbersome to collect and yet also has less immediate clinical utility. So in that sense, after clarification and tweaking of the processes, that we managed to have a more complete data collection processes, the subsequent accreditation process itself was then actually quite practical for us. So the process involved initial completion of a self-assessment survey that really serves as a quick understanding of where we were, and then an introductory call with the ICHOM team, and submission of the application form and the supporting documentation, which we understood that the requirements were actually not so much of really having a very perfect data set, but more of demonstrating that we do them consistently and we have the meaningful use of the data that are being collected for patient outcomes, and also ongoing monitoring of the response rates and completeness as well. Then this was subsequently followed by an interview where we presented our work and included the key stakeholders that were involved in the implementation process to really speak to the different aspects that more effectively. And thereafter, finally, it was then the accreditation decision. So we were quite glad that the ICHOM team, accreditation team, was very clear and supportive throughout the process, where I recalled some of our questions were actually addressed very promptly, and that really helped us maintain momentum and complete the assessment process in about a month. So we are really thankful for the incredible support provided by Louis and his team. And apart from that, another key enabler is that the effective cooperation between the various stakeholders was really critical, and that allowed us to collate the required information for submission very efficiently as well and ease the process tremendously. So what have achieving that means to us for now, it's really that for our clinicians involved in stroke care, as well as the institution, this is really an international recognition to the team that they are indeed practicing value-based healthcare principles and providing care that are considered important to patients. And to them, there is also a structured way to demonstrate progress of what they are doing, and at the same time having improved visibility beyond discharge with a clearer picture of how their patients' functionalities and quality of life are months after the acute episode. And then for patients, we do think that their now with their own perspective on their health status are now being captured as part of routine care, and it also helps to complement the typical clinical assessments that are being offered to patients post-discharge. And therefore, prompts that are being implemented are relevant to their care and not just being used for research as in some other settings. So we are now being more able to identify the unmet needs of the patients after discharge, where we generally have less understanding about, and the follow-up are more meaningful for the patients. So this takes us to what comes beyond level 1 accreditation achievement. And after receiving the confirmation, the certification report actually gave us a clear evaluation of where we are at now. And also it offers suggestions on what we can do to improve ourselves from where we are. So having our practices being internationally validated, our next focus is really on completing more cycles of data collection, definitely. And therefore, we will have cohort analysis, help to stratify outcomes by the case mix, etc., and eventually being able to have sufficient information to explore relationships between clinical as well as patient-reported outcomes. And this will then increasingly be embedded into our clinical workflows to really strengthen feedback loops and drive continuous improvement as per what was our original intent. So we also definitely plan to participate in learning collaboratives that will allow us to learn, share, learn, collaborate, and also innovate to accelerate positive change to outcomes that are important to patients. So before I end, I would really like to acknowledge and credit the entire team who has really made the journey possible. And now we are confident that we are really measuring what matters, that has been validated. And we also have gained better insights on how we can keep improving ourselves. Thank you very much.
Wonderful. Thank you very much, Sarah and Jim. A wonderful presentation, and I'm already seeing some questions coming through in the Q&A. So as I said at the start, it's just down at the bottom of your screen there. So if you have anything that pops into your mind as the presenters are speaking, please do fire it through and we'll get to those at the end. I'll just share my screen again. So our next speaker is Dr. Dominique from European Medical Center in Saudi Arabia. So I'll invite him to bring his slides up and speak about the wonderful work that they're doing.
Okay. I'm not able to share now. There's some...
If you give me a second, I can get yours up. And we can do it. Oh, there we go.
I'm okay now. I'm okay now, Luis.
Excellent.
Okay. So, hello everyone. My name is Dominique. I am a spine surgeon in Jeddah working at the European Medical Center, which in fact is an integrated practice unit focusing in general on orthopedic surgery, but in particular on spine surgery. We have been accredited level 1 and soon hopefully level 2 with ICHOM, and I will share with you some of my key drivers and experience in getting into ICHOM and into the value-based healthcare. In fact, one of the main key drivers was the patient, the healthcare from the patient point of view. As you all know, many of us are doctors here, I think. In our education, medical education, we used to understand medicine through crumbs and from the doctors and clinicians' point of view. I have met several times, and I have been with the Professor Michael Porter at Harvard, where we understood and we tried to understand how things can be when we see them from the patient's point of view. And in fact, a lot of things change when we look at healthcare from the patient's point of view and from the patient centricity point of view. So this was my main key driver. And of course, for that, I understood that when you are concentrating on the patient point of view, on the patient interest, then this patient centricity will lead you to better outcomes, to a best practice through improving the patient journey and adapting what you know to what the patient need. So for that, we started by creating, because I didn't want to have a fragmented orthopedic and spine care, we created our IPU in which everything is concentrated around this pathology. It was a full end-to-end journey, and we insisted and educated our personnel to have employees and our partners to have a full comprehension of what is the VBHC framework. So then we needed to align everyone to implement this vision of value-based healthcare in our center. We decided to concentrate and focus around the spine surgery. We aligned everyone, all those who were involved in the value-based healthcare and in the ICHOM journey into education. And we explained to everyone the interest and the importance of being patient-centered, of collecting data, of having a very fixed and agreed patient journey to improve and to facilitate the patient experience. Then we adapted, and this is very important, we adapted the data set of the ICHOM, but
It seems like we've lost Dominique.
I, I disconnected.
Oh, you're back again.
Yeah, but I don't know what happened. Okay, I'm okay now. It's okay.
Yep, yep, we can see everything, hear you.
So, so after having aligned our teams through education and explaining to them the interest of being of adapting the VBHC and ICHOM principles, we started by choosing. We took the standard set of the ICHOM, we translated it, and we localized it. Of course, we are talking about the standard set of low back pain. Then once we localized it, which means we made it into an understandable language by the population in Saudi Arabia, then we started collecting the data. What is very important to say is that we were not collecting the data as a hospital. We had Capadev, who is the partner of ICHOM. Capadev, through their platform, which is VIHA, was collecting the data for a transparency principle. We didn't want to be the one to influence the patient by collecting the data while the patient is with us. So they were collecting the data, which means that it was fully transparent. The results were fully transparent, and they were accepted and verified by ICHOM and by CAPADEF. Once the data was collected, it was very important for us because we understood from the patient point of view how we can adapt our treatment and our way of approaching the treatment in spine surgery. Personally, it allowed me to modify a lot my practice and my way of taking decisions regarding the care and regarding the patient by looking progressively at the outcomes from the patient point of view. So, 1 minute. Yes. Then once the outcomes were collected, this was the biggest impact in our practice. Let me explain some of my changements in the practice. You know, when we used to do spine surgery, if we take the example of scoliosis, for example, we were very happy to see that the X-ray in post-operatively was perfect. The spine was aligned. It was very good, very well aligned, and we used to, for instance, fuse levels until the very low in the lumbar spine. But these X-rays and behind our satisfaction and what we as doctor show and present in our conferences and our meetings, there was a human being, there was a patient. And we rarely used to look at the satisfaction of the patient. In fact, we understand very fast that the patient doesn't care about his radiology. What he cares about is his life, his dignity, how this girl who is 14, 15, or 16 years old will be able to adapt her social life. Will be she living without back pain, with back pain, when 10 years after, when she is 24 years old? Will she have a junctional syndrome? Will she have problems in the low back? Will she have pain? Will she be visiting us for pain management? So all this allowed me to modify my practice and be maybe less aggressive in my practice and adapt my practice to the patient needs, talk to the patient and design the care of the patient with him, explain the problem.
Just the same issue there again, I imagine. So hopefully Dr. Dominic will be back.
Like it's always like this. I mean, you see me again
No,
now?
no problem at all. Yeah, yeah, we're glad you're back again.
Okay. So I don't know where it stopped, but okay. So just to say that the outcome collection allowed me to adapt my practice, and I think that this is the most important thing. When we go into VBHC, when we go into outcome collection, you need after that to adapt your clinical practice to what you have collected. Otherwise, it would be without any interest. And our aim was always to improve the value equation. You need to have better outcomes at a lesser cost. And for that, we had partnership, and this was very important partnership with our payers, like Tawniya, for instance, here in Saudi Arabia, who were the first to be engaged in this value-based healthcare journey. And in this practice, we understood that we can, by being more efficient, reduce hugely the cost of our surgeries and improve the outcome of the patient. We have studied very closely our time-driven activity-based cost, and we have adapted it in order to become very efficient and to improve the patient journey. Oh, come on. You see me again?
Yeah, you're good to go.
Okay. So the we so in the our approach was very clear. So we started by localizing, by ensuring the patient engagement, by localizing our data set, adapting it to the realities and cultural relevant question. We educated our patient. This is very important, to explain to them why collecting the data is important and how it would influence their outcome and the outcome of the future patient that would be operated in our center. And then we had a proactive, and we ensured a proactive engagement from our team. We had doctors, male and female, who were helping the patient to follow up for their PROMS collections with the Kappa Dev, and to ensure that we had a big number of patients who were answering our questions on the data set. Then we ensured that our clinicians, because they were the biggest problem, that it was interesting and important for them. We explained to them why it is important to collect the data. It's not an easy matter to stay and always collect and look at the data and make sure that this data is that they are adapting their way of working on the outcomes, because it's very hard to explain to a doctor that he needs to change his way of working to adapt it. And then for this, we had a regularly weekly discussion with all the orthopedic surgeons and the spine surgeon who are working with us, and we did stuff, and we decided collectively on the best outcome to have and the best practice to have in our center. And then all that, of course, we integrated all that in our systems. The outcomes were all collected through the VIHA platform, and then we collected the results and we adapted our practice to these results. Of course, we were practicing the bundled payment, as I said, for the first time. We did it with Tawniya, who was the first insurance to go into the VBHC, and we adapted the bundled payment. We had bundled payment agreements, and we aligned all our incentives across the system. Thank you.
Wonderful. Thank you very much, Dominique. Lovely to hear of the excellent work that you're doing out there in Saudi Arabia. Now, our final talk is from the BDMS group in Thailand. So we'll have Dr. Parani, Dr. Piraporn, and Dr. Pongtorn speaking to us today. And I believe Dr. Pongtorn is going first. So I'll let them bring their slides up.
Okay. Thank you, Lewis. Okay. Hello, everyone. My name is Dr. Pongtorn from BDMS. So in this session, I I'm going to start first to introduce you to BDMS, and then Dr. Piapon and Dr. Parani will provide you some information about how we started and what is our journey. Okay, next, please. Okay, so BDMS, we are a corporate that provide healthcare services in Thailand and Cambodia. So right now we got 59 hospitals in Thailand and Cambodia altogether. We actually have run this business more than 75 years. But like around 5 or 7 years ago, we started discuss about how we can actually increase the value to our customer. And that's the starting point of we starting looking at the ICHOM. Okay. In BDMS, over the past 5 years, we start developing what we call Center of Excellence. The reason why we develop Center of Excellence because we think that as a hospital, we need to increase our capacity, our complexity of care. So then we set the goal to build some of the hospital to be a flagship and also Center of Excellence. So over the past 5 years, we have Center of Excellence for trauma, for orthopedics, for neuroscience, cardiology, and cancer. So we look at how we can actually draw attraction of customer throughout Southeast Asia or even in Asia Pacific. So we start monitoring about the percentage of international patients, case of refer-in or increase CMI. We try to set up the system in order to make sure that we can provide the best care. So we have been partnered with a lot of institutions like ICHOM or Oregon Health Science University or Hanover in Germany. But the ultimate outcome that we're looking at is the best clinical outcome to the patient. Next. So when we set up or assign each hospital to be a Center of Excellence, we develop the criteria to make sure that each hospital can achieve this to this criteria before we can announce that they are Center of Excellence. And then we designate them into startup level, ongoing level, and mature level. But overall, we having a trouble about how we can actually see the value that we deliver to the patient. So that's how we actually start looking into PROM and PREM provided by ICHOM and start working with ICHOM to focus more on value-based healthcare in recent years. Next. Okay, this is a clinical outcome that we start monitoring. So we can capture the data and then we compare the data throughout the hospital under our Center of Excellence network. Some of the Center of Excellence may have like 10 hospitals, but some of Center of Excellence may comprise of 30 or 50. So it depends on the coverage of Center of Excellence that we plan throughout the whole network. But in the past, what we monitor is just about process indicator or clinical outcome indicator, but we barely actually look at value-based healthcare outcome. Okay. Next. Yeah. So right now we start looking at because our mortality or the clinical outcome can compare to international institution around the world, and we know that we're second to none. So now what we want to go furthermore is to prove to the world that our service actually provide the better value to our customer, and that's the reason why we decide to implement ICHOM Accreditation in our Center of Excellence hospital. So we started it with Bangkok Pattaya Hospital first, and then last year we have Bangkok Pattaya and also which is a cancer hospital. And then this year in 2026, we have 10 more hospitals in line to get accredited in level 1 and also level 2. Next. Okay, next. So I would like to introduce Dr. Piapon, which is a hospital director for Bangkok Pattaya Hospital, to tell you about our story, our journey for ICHOM Accreditation. Dr. Piapon, please.
So thank you, Dr. Pongthorn, for introducing me. So thank you. Hello, everyone. I'm Dr. Piyapon from Bangkok Hospital, Pattaya. So I want to share some of our experience to join with the ICHOM. And the first question that come out when we join with ICHOM that why that our organization choose ICHOM for accreditation and why we choose stroke and TAD for accreditation. Firstly, as Dr. Pongthorn already mentioned that BDMS set a long-term development for Center of Excellence and be focusing on clinical outcome for the patient. At that time, when we comply all the standard guidelines and we can reduce some of the mortality rate for the acute patient, especially for the stroke patient and also acute MI patient. And at that time, we think that when we improve our clinical outcome by reducing mortality rate, but we cannot know for long-term outcome from our patient. That's why we're looking for something more valuable for our patient that we decided to apply for value-based care to implement in organization that we would like to explore more about the patient journey and we would like to understand more the patient and also would like to provide better outcome for our patient. Next, please. So at the time that in 2021 that we set our moonshot in Bangkok Hospital Pattaya that we would like to improving health and life expectancy for our patient and also our staff to greater than 85 years old. It's just a moonshot. It will be really challenging with the healthy heart and strong brain, strong bone, and also without cancer. The perfect that we would like to be, and then we test back that how we can improve our patient health and well-being. So next, please. So then we start with the review strategy from Center of Excellence to value-based healthcare in 2021, and in 2022 we decided to study for the patient report outcome from ICHOM set, and we study a lot for the value-based healthcare also ICHOM set at that time, and we decided to engage with the ICHOM and also discussion with the ICHOM team for vision and goal alignment to our organization, and we use the ICHOM prompt set to as the reference for patient report outcome, and then we start at the coronary artery disease set and also stroke because we have a lot of patients there, and also we have some data for patient outcome at that time, and I think that the both of disease set have high mortality rate. Also, we have a high volume in our in organization. And we start with the ICHOM with vision and goal alignment, and then we do almost the same as the previous organization, and we do the gap analysis and then team assignment, and together with the ICHOM consultation along the way for accreditation. And we do the data definition, definition, qualification, and also do the data collection together with the continuing improvement for our outcome, and also how to collect data more clearly, and also data is reliable. And we do the patient journey mapping and also design for the patient journey mapping to understand more and also engage them to report the outcome to our team. And then when the data collection already steady, we integrate with the IT team to design some application that we can collect the data from the patient report outcome, and we monitor the report outcome. And when we ready, we got the apply for certification from ICHOM level 1 in 2023, and with the stroke and CAD to ICHOM set. And in 2024, we use the prompt data to communicate with our care provider in our organization and what value that we get from ICHOM and how the outcome improvement for our patient. And we encourage our physician to use the prompt to improve care process and review all the goal with the patient. And in 2025, we communicate with the multidisciplinary team regularly, and we share our best practice to our BDMS hospital, and also share our practice, and also share the outcome to the public. And we got certified ICHOM level 2 for CAD and stroke in 2025 this year. So next, please. So what we get after we certify the ICHOM, definitely for the patient, we do more understand the patient for their goal, and also engage them for the treatment plan, and then we can see the improve of the patient outcome directly happen to the patient. And secondly, for the healthcare provider, our team learning a lot to use the guideline to create the patient journey along with the ICHOM consultation, and we can measure the patient report outcome, and we can communicate among our team that how to provide more better outcome to our patient. And also we collaborative with the another multidisciplinary team and create the specific individual care for each patient. And for our organization, Bangkok Hospital Pattaya, we gain a huge trust through professional clinical process. We gain trust among our clinical professional team that we believe in the same way that we would like to improve our patient outcome. And also we deliver the key message for better patient report outcome, and directly communication with our partnership with the third party provider, and also any collaboration that we have now today that we gain a lot of trust from them. Next, please. Okay, this is the example for the patient report outcome that we try to prove that after we implement value-based healthcare, and also together with the ICHOM, the use prompt set, how we can improve patient report outcome. This one is for stroke patient that for acute complication, we use the we measure the stroke complication with the aspiration, pneumonia, pressure sore, and we see just only 0.5 to 0.8% in hospital stroke complication in 2025. For post-stroke complication, that we have 99% 1-year survival rate, and also 99% stroke-free at 1 year. And for quality of life, we got the improvement for quality of life for our patient in 90 days. That improvement from 82 in 2022, increasing to 95% in 2025. And also for functional status, that our patient have good physical health status at 90 days, increasing from 47% in 2022, increasing to 86% in 2025. This is an example. Next, please. And this one, for example, for the outcome for a CAD patient after we implement the ICHOM accreditation, that you can see the outcome for the CAD patient after cardiac surgery. Our patient that they have free of chest pain dramatically change, and also the loss dyspnea also improvement significantly. And especially for the readmission rate, that we can decrease readmission rate in 28 days from 2.14 in 2023, decreasing to 1.08 in 2024. This is an example, and that's all for I would like to share for Bangkok Hospital Pattaya that we certify for ICHOM level 2. Thank you so much. I hand over to Kun Parani.
Yes. Kun Parani. Hi, Kun Parani.
Dr. Pongthorn, could I
Okay.
share one slide by myself?
Okay, sure. So Natit can stop sharing, and then Dr. Parani can share her slide. Thanks.
Okay. Good afternoon, everyone, and thank you, Dr. Pongthorn. I'm Palani Pongapakun. I'm Hospital Manager of Wattanusot Cancer Hospital in the Network Hospital of the BDMS. Thank you very much for having me today. Wattanusot Cancer Hospital have a journey toward becoming the world first to achieve ICHOM Level 2 accreditation for breast cancer care. It's very proud of our hospital. The achievement starts strong by starting that Wattanusot is the first in the world to reach level 2 of the ICHOM accreditation because of the vision is like accreditation explain that the core value driver we need to transform volume to value uh, and certify is confirmed that our vision is collected to the right way. Because of the volume-based model is focused on the procedure or survival, but the value-based is focused on the patient well-being and function. That's like the same vision of the ICHOM. The core philosophies emphasize the care beyond cure. Is this right now is the core vision of the Wattanusot Cancer Hospital to care the cancer patient, and we need to expertise in curing but commitment to lifelong patient care. This is a implementation journey of our breast cancer care program because of we started from the best practice. We developed the guideline of the breast cancer pathway in the year of 2010 to 2021, and after that we have the JCI accreditation. Then our hospital director, Dr. Thirawut, he need to find something to confirm that the outcome of our patient is correct too. Then he find the ICHOM, like the outcome of the patient is the reference is very interesting. Then we started to study in the ICHOM reference in the year 2018, and after that we developed clinical workflow. The first one not aligned with the ICHOM, and we correct and aligning clinical workflow with the ICHOM. And we started the IT support to EMR integration to prompts directly to the EMR. To the start from the year of 2019 to the present, we collect the data of the ICHOM in the EMR by PLOM and CLOM. The strategic pillar highlight the triad approach user transformation, clinical leadership, IT integration, and patient engagement. The system integration, we mentioned that clinical workflow were redesigned to integrate prompts directly to the electronic medical record. This is a tool that we using in breast cancer. The patient report outcome. We use the EORTC QLQ C30, EORTC QLQ BR 23 first, and the present we use the EORTC QLQ BR 45 and base Q that we collect the data for the patient satisfaction after operation by the type of the surgery, conserving surgery, mastectomy, and also reconstruction surgery. And the outcome set expand that we collect three types of the data, and case mix variable depends and rely on the ICHOM reference. This is our patient journey of the breast cancer pathway. You can see since the patient access to our system, like the care in our hospital, we have the coordinated nurse to provide the care and follow, escort the patients every step of the care of the patient until the survivorship. Then we collect the data for 10 years to collect about the quality of life and also rely on reference of the ICHOM. We have the real-time monitoring. It's showcase like a use of Power BI for the CPLUM registry, allowing provider to monitor the quality of life metric like social, emotional, and physical functional. Right now, we collect the data over the 5 years. This slide will show our patients have the high engagement, point to our success in data collection with an overall response rate more than 85%. Note that from the baseline pre-operative response rate consistency about 100%. This slide will show the example of the quality of life by the tools of URTC QLQC30. You can see we compare the quality of life by compartment, like from the baseline 6 months, 1 year, 2 year, 3 year, 4 year, and 5 year. This is demonstrate that the summary of the our patients, if have early detection of the complication that have the most of quality of life is will be get better, and when in the timing of treatment in real situation maybe decrease of the quality of life, but our patient will be get better. That means our hospital is can care of the patient to get the quality of life. When I implementing the ICHOM in our hospital, is like we have to shift toward to value-based healthcare by moving from volume to value. Healthcare provider can achieve far better clinical and personal success. Below is the breakdown of the success and key learning from using the ICHOM standard set. We can shift from the survival to quality of survival. ICHOM set shift focus to the long-term quality of life, and it capture outcome that matter most to the patient, such as body image, sexual function, and emotional well-being, which were previously overlooked in standard clinical chart. And enhanced shared decision making. The ICHOM set use patient report outcome measure to gather data directly from the patient. We learning that these data allow doctor and the patient to have more honest conversation, like at the same language. For example, a patient might choose a less invasive surgery if the PLUM's data show it lead to significantly better physical, functional, and body image, even if the survival rate are identical to the more radical procedure. Early detection of the complication. If we use the PLUM by systematically tracking symptoms to standardized questionnaire, the success of our hospital show that global implementation have shown that regular PLUM collection help clinician detect chronic pain, depression, or lymphedema much earlier than waiting the next scheduled follow-up appointment. That means the questionnaire is less concern also from the clinician and patients. The last one, if we collect the data and more like the data collection, we need to global benchmarking and transparency because of the set is standardized international. That means we can benchmark the excellence worldwide. Our success that our organization have used this metric to build a culture of the continuous learning, identifying where their clinical pathway were efficient and where they need redesigning to reduce and improve patient satisfaction. This is like our vision to blend or integrate with the ICHOM. Care beyond care is our mission for this year and the next to care of our patient, our cancer patient at Butternuts Hospital. Thank you.
Wonderful. Thank you very much to the BDMS team. If you can just stop sharing your screen, Parani, that would be great. Thank you. Okay, we'll get straight into the Q&A session. We've got quite a few that have come through, so I'm going to try and get through as many as we can. The first one is to the Singapore team. That was kind of already answered, but I'd love if you could elaborate more on the amount that you communicate the idea of PROMs and also ICHOM accreditation to your patients and kind of their response to that.
Thank you very much, Louis. As mentioned, we do have a patient information brochure that we provide to patient to communicate on what are the expectations they can have on communications post-discharge for them. Therefore, to expect that there's going to be surveys to ask about how they feel, etc. And really emphasizing that this are to help with their care, to really understand their perspectives and incorporating their views into organizing the clinical care for them. But not so much about ICHOM accreditation because I think at the moment it's really to socialize the concept of them getting understanding that their viewpoints are taken into account when their care is being decided.
Wonderful. Anyone else from the Singapore team that want to contribute to that answer?
Yeah, hi, Deidre here. Sorry, I'm not sure why you're not seeing me, but my camera is on. And I'll try it again after this question. But I think that I agree with Wanjin. The patient's perspective is they want to know that they're being heard and that we're addressing their specific issues. On a systems level, we can communicate it to them, but to an individual patient, that's not particularly important. So I think one is to say this helps us to improve the care for you individually, but also as a system for us to improve care so that they understand that we are looking at it on a systems level as well. But the accreditation part of it, the patients, it doesn't really mean very much to the patient, though it means much to the system.
Yeah. Wonderful, thank you. We had quite a few questions come in about the way that PROMs are collected and things like that. And so I wanted to hand this one over to BDMS because I know that they have their own platform that they built. So if someone from BDMS wants to respond to that question.
Yeah, sure, Lewis. So at BDMS, we have 4 hospital information system among our 59 hospitals. So we cannot rely on one EMR. So at the end, we develop our own patient registry for each disease for Center of Excellence. And within that, after we learn from ICHOM, so we construct our own platform to collect PROM and PREM by using ICHOM questionnaire set. And then we integrate that platform to EMR. So right now, we be able to integrate to any platform, any HSS in that available in the market because we know how to connect to that. And that actually reduced the workload for clinician to document because the system actually talk to each other. So the data from EMR will be integrated and run into the PROM and PREM questionnaire collection platform. And we can send link to patients so patients can answer to the questionnaire by themselves. So we do not require any nurse or physicians to interview patients. So that actually reduce our workload as well. Yeah.
I imagine as well that kind of full integration means it's much easier when a clinician is talking to a patient, they can just pull up all of that data straight away.
Yeah, and then the clinician don't have to switch from one app to another because it's actually located in one location. Because we can be able to put the link on the HIS, so you can open just one platform, which is HIS, and then you can go through everything from registry to PROM and PREM.
Wonderful, thank you. Dominic, there's a question here that says, well, I understand the value of collecting PROMs and patient outcomes. How do they benefit the field of health economics? And I know you've done some stuff around bundled payments. So I was wondering if you could speak to that question.
So, in fact, it is deeply linked because let's start from the beginning. The value is the value offered is always better outcomes to a lower cost. So the aim was to bundle the payment in order to take into consideration the whole journey, the whole episode of care, starting from the pre-op until the post-op in our.
Be back with us again, Dominic? Are you gone for a little bit longer this time? Mark, are you there with them? Are you able to? Oh, you're back, Dominic.
I don't know what's happening. Okay, so we took the bundled payment allowed us to take into consideration the whole cycle of care for a certain episode, and then we did. This is how we adapted each episode of care in spine surgery to the bundled payment. So it affected a lot our economics, and it goes in pair with the value offered in VBHC. It's always linked the outcomes and the cost by improving the efficiency, by improving your pathway, improving your diagnosis, and your decisions to operate or not. It's very important because don't forget that you are the one who is responsible of all of any complication that may occur after the surgery. So without being a cherry picking, because this is the biggest problem, without a cherry picking the patient, you need to remain always ethical, and you need to really choose your indications and to adapt them as per the patient needs.
Wonderful, excellent answer. And I do just want to stay with you, Dominic, to ask how have colleagues in other clinical areas viewed your work, and will we see a similar approach in other departments at EMC?
Excuse me?
Sorry, how have your colleagues in other clinical areas viewed the work that you've done around implementing the ICHOM set, and will we see a similar approach in other parts of EMC?
Yes, of course. At the beginning, it was extremely challenging because VBHC and ICHOM were something very new to the market. Of course, KSA is leading, is one of the biggest leaders in the world for transformation and adapting the healthcare to value-based healthcare. But a lot of our colleagues did not, and institutions that we had, did not understand what is value-based as a healthcare and the interest of having value-based healthcare and adapting it to their daily practice. And we all know that asking a doctor to change and to modify his way of working is extremely difficult. So at the beginning, it was very, very difficult. Then with time and by explaining the interests of such a practice to our colleagues. Now we see a lot of hospitals getting an institution wanting to get into the VBHC, but it was not easy in the beginning to do it. And I think that we had a lot of chance to have with us some of the payers. One payer who accepted to bundle the payment to go into the value-based healthcare, and it was something excellent for us.
And it's, excellent to have pioneers like your institution in the region driving this forward and kind of showing the way to other organizations so that they can then start to come on board and implement it as well. I want to ask a question to Singapore and BDMS, but I'll start off with Singapore. And the question is, how has ICHOM accreditation made any difference to staff? E.g., does it help with recruiting or training clinicians? Do they feel positive about being known for a patient outcomes focus? Singapore, if you want to.
Yeah, sorry, it's Deidre here again without the video, but I am here. I think, from a clinician perspective, recruitment and such, it for the way our system works and we're a public healthcare system, not so much, I would say. But I think clinicians are interested. Clinicians do want to know what they can do, and that these issues that patients may be experiencing are addressed earlier rather than later when, the consequences may be resulting in a readmission, or where something can be done to prevent worsening or progression. So I think people are interested in it, but from a public health perspective, not so much for recruitment. I do think that, as Wanjin shared during her presentation, there's a lot of organization that comes that is required to start up. So you do need to recruit staff, or have people like Wanjin and Dusit from relevant departments help individual clinical teams with this. And while it's running, to collect consistent data that there is action items that are followed through, you may need to see how staff are redesignated to take on some of these tasks. And sometimes you might need additional people to handle the tasks. So yeah, that would be our experience from Singapore.
Wonderful, thank you. And BDMS, do you have any kind of further thoughts on that or perspectives?
I can speak on behalf of BDMS as a network. So we actually gain recognition once when we start doing ICHOM accreditation. So many organization payers start talking with us and quite curious about why, as a private entity, we decide to go on value-based healthcare, which is funny enough, because we thought that value-based healthcare will help us to define the value to the patients. At a network level, we try very hard to see how can we improve. So once when we learned from ICHOM accreditation, we actually found that our usual KPI that we're monitoring right now may not really reflect the value that we want to deliver to the patients. So I think it's really helpful in the way of redefine the KPI monitoring at the network level and also hospital level. And in the meantime, interestingly, clinicians, without implementing ICHOM, many physicians did not think about empathizing the patient's outcome. But once when we start using PROM and PREM, we have seen many interest from clinicians who never thought about empathy before. So I think this is something that quite surprised us, and it helped us in terms of how we can actually provide a better care to patients. So that's from our experience.
Thank you, Pongton, and it's great to hear that perspective kind of from that network level across all of your hospitals. We have a question here that is there a rough % completion rate that you need to achieve level 1 and level 2? And I'm more than happy to answer this one. So For our criteria, we have minimum eligibility criteria, and for level 1, we want to see at least 50% of the ICHOM set being used in terms of the CROMs and PROMs, and then also a patient response rate of 25%. And then when we shift to level 2, that moves up to 80% of the set being used and a 40% patient response rate. And then within that, we also want to see a minimum number of patients who have had baseline and follow-up data collected for them. So for level 1, that's 50 patients, and for level 2, that's 80 patients. But for anyone that's interested in the program or the criteria in more detail, please get in contact with me and we can discuss that through on a call. Just looking at some of the other questions that we have. I wanted to go back to you, Dominic, and ask about the outcome questions that you had in your talk and how you developed those. Was that in consultation with consumers or a clinical group?
Sorry, I shifted to the computer of my friend because I'm disconnected from my computer. So I would have wanted to show you to share our results regarding the outcome. But to answer really the question, it helped us a lot because in the what we collected on the VIHA platform is, of course, the data set of ICHOM, the ICHOM data set. And in this approach, you will have the pain. We collected the results of regarding the pain, the disability. So we had the pain score. We had for the back pain, for the leg pain, and the personal care, the social life. So it was very important to know that before surgery, how was the personal life, the personal care, for instance, for a patient, because this is important for the patient. That's what matters for the patient. His social life, his personal care, how he was able to sit, to stand, was his life easier? Was he able to travel, to socialize better? And in fact, these things we do not care really about when we collect the crumbs. These are pure crumbs, and they are very well seen and analyzed in our in the outcomes of the ICHOM data set, and they were analyzed on the platform of VIHA with Capadev, who were collecting the data. It allowed me to understand that maybe without doing a fixation, the patient in spine surgery, the patient was having a good life, a good social life, depending on his age, on what he does every day. So it adapted a lot my way of working for the cases where usually in our education, medical education, we were used to do, for instance, fixation of the spine. In this case, I noticed that even without that, patients were having good life, were having good social life, less pain, less back pain, less leg pain, less risks and complications. So it allowed me a lot to adapt my, and I saw this. I mean, we see this with numbers, with percentages, and like that, you can adapt easily your way of working. You adapt your crumbs to the prompts, and this is, I think, thing about the value-based healthcare and the ICHOM. We can adapt your way of working with what the patient needs.
I really like that part you said there, if you adopt your crumbs to the proms. I think it was kind of really hit the nail on the head, and you actually mostly answered another question I was going to raise, which was, can you give a specific example of changes resulting from the work? But I'd also like to open that up to BDMS in Singapore, if there's anything you want to comment further on that as well.
Okay, I can go first. For BDMS, the changes that we actually see is how we design our system. Because without learning from ICHOM, we may not have PROM and PREM be part of our clinical documentation. So we never think about the HAS that actually embedded with PROM and PREM. So that changed our mindset, how to select the new system, the new platform, and then we need to redesign the workflow. So that the obvious change that we actually saw. The second one is about I mean, this is on the business side. We actually see the value of using patient experience to advertise our work and also reach the target, not only about the clinical outcome, but also the patient's experience. And that is very helpful in emotional campaigning. Yeah.
Lovely, thank you. In Singapore, do you have anything else you want to add? No? Excellent. We just have probably time for one more question, which is a quick one here. So, how is PROM scoring calculated? So each PROM survey has kind of a matrix that they provide with you when you go through that scoring as well. And then the other question was how PROM's data displayed in the EMR for physicians to use. And I think this was kind of covered off by Hong Kong for BDMS. They have their own platform that they're able to go into and bring up all that information. But as well, from the work that we've done with different organizations, we see that each place maybe has their own platform that they have or their own dashboard that they have that allows them to look at this data. Okay, so that is unfortunately all we have time for in terms of the Q&A. I want to just move on to a couple of housekeeping things before we finish up. So before we close, we want to offer the opportunity for those of you who'd like to stay involved beyond today's session. At ICHOM, we're shaping a new initiative focused on strengthening how our community is represented, engaged via a membership group. We're inviting a small number of participants to share their perspectives directly with our team. So we're launching a quick poll now to see if you'll be open to having a short kind of 15-minute one-to-one Zoom conversation over the next week. This is completely optional, so you certainly don't have to sign up if you wouldn't like to. But if it sounds useful, you can leave your email address in the poll and we'll be in touch soon to discuss things further around that membership program. And I'll just leave that up for a little bit while I bring up the slides. So while that's up on your screen, you'll also see that we have our QR code to the implementation directory. So this was asked if it could please be shown again. So again, please scan that QR code. You can also find on our website links to it so that you can go through and fill out that survey as well. And then I'll just leave that up for a little bit too, so people can click on that. And while we're doing that, I just want to extend my sincerest appreciation and thank you to all of our speakers today. I think it was a really, really interesting range of talks. We covered off a lot of different topics, and it's great to be able to publicize to our kind of network the amazing work that you've done and the experiences that we've been able to have with you through accreditation. And then the last thing is our next webinar. So we have the BDMS team back again in about a month's time. They'll be talking more specifically about the work that they've done around enhancing the acute stroke care system for optimal treatment outcomes. So very much looking forward to having them back, and that session will be moderated by one of my other excellent colleagues. So please do, if you haven't already registered for that, by scanning that QR code there. And I'll leave that up for a little bit as well. So as we said in the comments, this will be recorded, sent out to everyone as well. My email's there. If you want to get in contact, please do reach out. I'll be more than happy to have any conversations with anyone if you've got any questions or you think you're ready to apply for accreditation as well. So thank you very much all for joining, and I hope to be speaking to a lot of you soon.
Thank you, Lewis.
Thank you.